Just a brief little, oh, perfect. We're recording. Just a brief little summary of what this was. Um, Actually, Elizabeth should give that summary. So why don't you share?
Sure. Um, I gave a presentation that Jalene, Caroline, and I worked on for months and months and months to the Washington State feeding meeting. So that's feeding providers across Washington State. Thank you, Jessica. And Jessica monitored the chat for me while I did it because we were down a couple people that day. And basically it is a vision presentation for feeding therapists. So some of this, a lot of it, is going to be full of information that you already know and already have access to, but we tried to create intersections for vision and feeding in a way that was meaningful for feeding therapists and kind of gave them some ideas and options of things to try, as well as different reasons why kids may not be able to access feeding in the ways that they might expect and what those potential impacts might be and what are some indicators of those impacts. And then also we gave them all of your information so that they could contact you or contact your where you're located and figure out if they needed a consult and what to do and who to contact in that case if they weren't already aware of what their general area in Washington was doing. So that's the background. And then we'll talk about kind of what we did. So just what I said, it's identifying indicators for potential visual impairment, teaching them how vision can impact feeding routines, and then to increase their understanding of supporting feeding when vision is impacted.
Thank you, Elizabeth. So the introduction to this is a great video that you might recognize the star of the video of a 10 to 12-month-old roughly during feeding. And the intention or thought when watching this would be to think about what are you noticing with this child's vision? How are they using vision to access the feeding routine and environment and relationships? So feel free to put in the chat if you want to put in your thoughts about what you're noticing or hold them in mind. We can have a moment to process together. So here we go. Hopefully this works. Elizabeth, let me know if this doesn't work for
I
any reason.
don't know if the sound is going to work.
Oh,
Sometimes it
good
does,
point.
sometimes it doesn't. We don't,
Probably
it's
not.
okay.
So
It's okay if it does not.
okay,
You can
sounds
still
good.
watch it.
What? What? Do you want some more pouchy? No. You want water? Your hands up. I'm just going to go back and watch that 30-second clip again, just so for the second time you can get a moment to look at what's going on vision-wise. What? What? Do you want some more pouchy? No. You want water? Your hands up. Awesome. Okay, I see from Jessica looking at the cup. Anyone else have any thoughts about what vision was happening in this feeding routine? I know I'm speaking to a bunch of vision specialists, so it's okay if it's like, okay, we know. I can just point out that if you are looking at the tray, there's some food that doesn't have the most contrast. So there's some puffs that are kind of blending into a whitish tray. Yeah. Anyone else?
I was just going to add that, Jalene, and you could probably watch that clip 100 times, honestly. And there's just a lot happening, but so much communication too. Randy had a comment. She also used a visually guided reach to swat away the food pouch. I like that, Randy.
Great.
So, and then basically that video was shown prior to the presentation so that the feeding therapists were able to use their feeding therapist lens on it. And then we started going through information so they have a better understanding of what impacts kids' ability to feed. So 80% of a child's learning is through the eyes. That's from the American Academy of Ophthalmology. And then 1 in 4 children in the United States has a vision problem in the US. So that is not all of who we're seeing. We're seeing, the exception to the exception to the exception, right? So potentially when you have children with other impacts, that number could be different in our population of kids that we're seeing. And because feeding therapists are seeing a lot of premature babies, and so that increases the likelihood that there's possibly a vision impact for those kids. And over 40% of the brain is involved in processing and supporting vision. And that obviously leads itself to, if there are impacts on the brain, that there's also likelihood that there's a processing issue in the brain, and that is potentially going to impact your ability to use your vision.
Hey, sorry, I had missed Stephanie's comment. So she just commented how well mom follows child's cues, and that, for declining the pouch and giggling, when, she gets what she wants and communicates that so nicely.
She still does that. So there are 2 types of visual impairments. There's ocular and neurological. And neurological is where your ocular components of your vision, i.e. your eyes, and all of those working parts are typical, and there's something going on with the picture after your eyes take it, and where the picture is received in the brain and your brain's ability to process the picture that your eyes took. And ocular is basically your camera taking a picture. And there we go. It's ocular visual impairment is like a filter. So like nystagmus is making it so you don't really have a clear picture because you're looking at all of the things. And CVI is not about the filter, but about the processing, right? So you take a picture and you have your film, but you can't process the film because there's something that's interrupting that process. Oh, it's still my turn. My goodness. We color coded so we know whose turn it is. And then what is CVI? It occurs, as you guys all know, when there's damage or disorder of the visual pathways in the visual centers in the brain, including the pathways servicing visual perception, cognition, visual guidance of movement, those things. So it really, like when we say 40% of the brain, you often get some kids where it looks like they're just not interested in something and not attending to it. And one of the things that we always try to remind people is that babies don't get bored, and babies are never not interested in something. If they're not looking at something, there is a reason for that, but babies generally are interested in all the things. So.
Great. So thanks to our amazing babies count, we've got some data that you all are very well aware of. So maybe this is just a slide to say, remember to do babies count, get in that data. But anyways, yep, the registry found CVI, ONH, and ROP being some significant vision conditions that I would anticipate our caseloads reflect in that way to some degree. So anyways, we're mostly just sharing that information with the feeding therapists who might not be as aware of what are those prominent vision conditions we come across, if we even have some diagnoses there. So some indicators of possible vision impact during feeding, these similar, I guess, to the TPA sort of approach. What are we looking for? What could be an indicator if we don't already know there's vision impacted? So some of these might include a head tilt or turn while attending to the feeding activity, the parent or caregiver or the tray. Maybe the eyes are misaligned when trying to focus, or there's an involuntary eye movement. Maybe you're noticing the child is missing visual cues during that feeding routine. So maybe the spoon coming to the mouth is quite startling, or they're not motivated by what they're seeing. So there isn't that excitement when whatever the bottle is brought out or whatever the visual target might be in that feeding routine. And then is the child distracted by lights, or do they have difficulty focusing on the target at hand? Are there other pieces getting in the way of focusing? And I guess, like I said earlier, are they startled when the bottle or spoon approaches their mouth? Were they not anticipating it, or didn't have enough information to know that something was so close to them? Are they using their hands to find items on tray? I find that this one is fairly common with the children I come across who are compensating so sneakily that they are so good at using their hands to find items and independently can get it to their mouth, but they're not necessarily attending to the object or the food on the tray. And maybe they look away from the tray while interacting with the food. We're not seeing that visually guided reach like we got to see in that video earlier. And maybe they seem to ignore that food that blends into the surface, just also like the video, those puffs on the surface. Maybe those seem to be ignored, or maybe even different parts of the tray are ignored. And then is the child swiping to clear the tray? So they're not necessarily able to know that there's this thing in this exact spot. And so there's more of a gross motor movement swipe. So on the screen is a chart I created a couple years ago that is just how my brain was holding in mind some different categories of kids that come or that are referred or get sent to our intake coordinators most frequently. And so this was something I shared with intake coordinators, referral coordinators in King County, because these were the ones that I was seeing come in so frequently. So I've got 5 columns on here. There's the vision and diagnosis, prematurity, neurological impact, NICU stay greater than 5 days, and any caregiver concern related to vision. So I shared with intake coordinators, referral coordinators, if any kid comes in with these diagnoses, include me in it right away. And of course, this is not all encompassing. There's so many others. This was just for me what made sense in my brain. So if anyone has ideas, would love to hear, but also if you want this chart, I can send it out. But this was something we shared of just, keep in mind with these columns, but also there is a lot of overlap as well with prematurity and NICU stays and neurological impact and vision diagnosis in itself. So yes, this is still me. And then how vision impairment can impact feeding. So we saw like what could be an indicator of vision impact, and this could be the impact we're seeing. So fundamentally, unable to associate sounds in the kitchen to food preparation. Just today, I was at a home visit with a child with bilateral retinal collibomas who an optic disc collarbone, super interesting, but he was super upset and needed a bottle. Mom went to the kitchen and he still freaked out. It just seemed like he did not understand where mom was going, what was happening, to get the bottle in the kitchen, bring it back. And then the child might have difficulty anticipating what are the steps of the mealtime, and is it dysregulating when something happens that you weren't expecting? Are they limited in how they're seeing people eat and using utensils and cups? So the imitation of that feeding experience with other people might be missing because of not being able to get that information visually. And maybe they're thinking bowls and cups arrive out of the air, the bottle arrives out of the air, not knowing those steps of what happens beforehand to develop that concept. Are they overwhelmed by lots of noise or visual clutter or sensory clutter even? Does the environment impact the feeding routine significantly? And does a disruption in signals or pace of feedings really throw off the child's experience based on what they're understanding and processing visually?
So next we talked about sensory impact, and if kids do have a visual impairment, the things that they're going to need to do to be able to gain that information that they're missing out because they're, for whatever reason, not seeing it. So Oftentimes kids will need to rely more heavily on different sensory learning channels of touch and auditory particularly. And then at the same time, those channels will potentially be more sensitive. So noises could startle them more because they're more attuned to listening to things. Sometimes they'll also require more processing time because they need to then take in that information and sort of apply it in multiple different ways. And then also fatigue is going to be a part of that, because when you're overusing anything, you tend to feel fatigued, particularly if you think about sitting at a computer screen, like writing a paper for 4 hours, your eyes are toast, but your body might be okay, but that's, your eyes and your brain are tired, and that's going to maybe impact the rest of you. And it's going to impact your ability to go about your day nicely and happily. And then also thinking about, even if they can attend visually, what that's doing to them, their impact, their ability to sustain their attention and understanding and process what's going on in a way that's teaching them something and where they're actually learning is impacted. Because if you're working so hard and using all your energy to focus on something, you're going to get really tired. You're going to be really cranky, also because you're a toddler or baby. And so you're going to go that way anyway. And then, things that you guys see all the time, difficulty pairing using your vision with your motor. So integrating your different sensory channels can be difficult for some kids. And then because you're working so hard to focus on the feeding, that's going to take away your ability to accurately scan your surroundings and understand the greater context of what's taking place. So if the food magically appears on your tray because you don't have the ability to deal with what is going on in your background, right? The area that's outside of your tray, that's going to impact your ability to feed and give cues, because you may not understand that there's anyone in front of you waiting for your cues that you need to eat. And then particularly kids with obviously like CVI, multisensory input can interrupt visual processing. So if there's lots of someone's just talking at you nonstop, you may not be able to listen and watch at the same time. And so it's going to be harder for you to see those cues of like a spoon coming at you because someone's saying, "Here comes the airplane," and you have to look away and listen. And then all of a sudden there's a spoon in your face. So those are some of the things that being therapists need to think about. So what can we do? We can adjust the feeding environment by changing the color of objects, changing things from 3D to 2D or 2D to 3D, probably that direction, reducing the complexity. For people working on maybe reducing the number of people that are in the child's line of sight, working on some skills outside of feeding, like facial recognition and attention in settings that have less going on in them. Creating routines, as we all know, babies learn best through routines. So creating routines around feeding so that there's less novel content taking place and kids can learn to anticipate what's going on because it's been repeated a lot and they've learned it. And so that's something that they're able to process and start to anticipate, which takes away some of the need for doing extra processing. As cute as baby placemats are, sometimes they're a little busy. And so finding ways to reduce as much visual complexity as possible. Sometimes you could even, I've seen this once, somebody set something up so that they had like the mom was like, had a black curtain behind her. So it was just her and the baby couldn't see the rest of the kitchen. And that is one way of taking away some of the visual complexity. And then thinking about, what we talked about in the last slide was sensory environment. So thinking about, are there lots of cooking smells that are different from the food that the child's accessing? Is there a lot of movement and other things happening in the environment that are going to affect the child's ability to focus on what's happening at hand? You know, are the lights shining in the child's face? Is their tray reflective? Like in that video, that's a shiny tray. So if there was any overhead light, that's going to potentially have some glare related to it. Do you have a noisy dog who is barking? Do you have siblings who are screaming and fighting? You know, those kinds of things could potentially impact the child's ability to use their vision to access feeding. And then, as all OTs know, positioning, 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 and the child needs to have their feet flat and, 90-90 as is appropriate for each child and their specific circumstances, but not loosey-goosey, right? Because we know if kids are not supported motorically, they're going to be using a lot of bandwidth to try to get themselves in a place where they feel stable, and that's going to take away their bandwidth for using vision. And then also thinking about how mobile they are and sort of what their motor skill set is, and is that conducive to them sort of using visually guided reach and other things like that. So trying to set up the environment so that they have the least amount of work to do motorically if you want them to access things visually. Okay, my turn again. Jalene, she color coded these and I didn't look at it ahead of time, so that's on me. So increasing visual attention during feeding routines, just like we talked about before, decreasing visual or background clutter, also clutter on the tray. So thinking about not having 10 kinds of food on the tray, even though it's great for experimentation, but maybe just having one thing and maybe not a large amount of it, depending on what the kid is able to see. Turning off background noise, TV, music, talking, reducing as much of that sensory input that we talked about on the last slide as possible, so that the child is able to use their vision if they've got it. And then we talked about glare. Having your child facing outside is lovely sometimes, but facing away from a window is a nice way to get some nice light in the room, but not directly on the child's face, or not in a way that it's hitting their tray and reflecting on them. And we all love a good black matte, or red if they need it, or whatever their color is. And then wait time, which is huge. And I think a lot of people forget that vision impairment equals longer wait time, because of that extra use of other senses that they need to use for processing. And if they're using their vision and it's not their strongest learning channel, that's going to take more time, and they're going to have to think about it a lot more, particularly if it's a new food or a new flavor or a new experience.
Awesome. Thank you, Elisabeth. So some more touch and auditory specific strategies. So the touch progression strategy, so where the caregiver or adult touches the child's elbow, then moves their hand up toward the child's mouth, giving them the tactile information of what is happening where on their body and when they can anticipate something's coming toward their mouth, rather than it just appearing next to their mouth. And as we've said many times through this presentation, routine. So having that consistent routine where there are specific steps the child can begin to anticipate and eventually take part of that routine. So the child sits in the chair, for example, gets a washcloth, and then maybe that washcloth stays with the child during the feeding, but they've got that object cue with the washcloth, and then a consistency with the routine. And then having consistent verbal cues, such as here comes a bite, but having that auditory information of what's about to happen to anticipate. And then our good old hand under hand strategy of having the caregiver's hand underneath the adult's hand, or sorry, the caregiver adult's hand underneath the child's hand. And we've got some amazing resources from WSDS on what hand under hand is. So it is when the caregiver or provider's hand is under the child's hand to guide the child's hand to the target. So the benefits would be the child can get the same access that others might have with using their hands through that guidance. And it encourages that authentic involvement of the child so that they can eventually perform independently, but first to learn maybe not independently what that motor movement feels like to get toward that target. And it also allows the child to have the access or remove themselves from the situation, that they're the ones holding that agency. WSDS has this great video, though it is a little blurry, so hopefully it comes out, but we can just watch a little clip of it to see an example of what hand under hand might look like. This is not part of a feeding routine, more of a play routine, but still a great example, especially for, feeding therapists have never seen hand under hand. They would be able to view this. Awesome. Do you want to see that again, or was that sufficient? I guess.
That's a great example. I love that, just like that invitation. And I just wanted to add, Stephanie made a comment about really liking how you all talked about how having the child's feet flat on a surface makes a huge difference. And just kind of wishing that more affordable high chairs came with footrests.
Yeah, I mean, I think if that's an issue for kids that you see, I'm guessing they probably also have some sort of motor therapist, and that might be a good brainstorm with them to figure out what you can do. I know for older kids, you can get some like strong surgical tubing and tie it around the front legs of the chair, and kids can put their feet up there. But yeah, it's definitely a problem. One of the ways you can kind of combat that is just really putting like towels and things on the sides to really squish a kid into their seat. Because the other thing too is if you're feeding really young kids, high chairs are not made to fit them. So their little leggy schmiggies are just out straight most of the time anyway, because they're tiny. Yes, surgical tubing is also great for older kids who have like ADHD and need to wiggle their feet or their legs. You can stick that around the bottom of their chairs and they can just bounce, and it doesn't bother anybody, and it's not really loud. So for the wiggle worms, it works for adults too. All right. So
do you want to take this one, Elisabeth? I gave you a lot of slides.
I will be fine.
Okay.
My best wife and deal with it. So thinking about facial recognition and eye to object considerations, one of the things, obviously if I'm way out here, you can see all of this, but if I'm up close, it kind of cuts out some of the clutter. So that's what we talked about, using contrast to increase the likelihood that someone's going to see it. Also, we did this before we talked about the light pads, but use your light pad to your advantage. Okay, guys, use that light pad. A 2-gallon Ziploc bag fits over the free light pads that we got from WSSB. So you can just turn it on, pop it in the 2-gallon bag, zip it up, and make sure that the writing part of the Ziploc is on the bottom part of the light pad. And then you can just get messy on there and it's fine. And they wipe right off after that. So using contrast, some people will use like a dark lipstick to highlight their facial characteristics. I have colorful, kind of thicker rimmed glasses because it makes it easier to look towards my eyes. And making sure that, especially if your child has sort of an atypical tilt or turn or gaze, positioning your face within that child's field of vision. We don't want them working hard to try to see you if you want them to see you, right? Where this isn't, a lot of times with feeding or motor, we're working on the just right challenge. Our job is to take away any challenge the child has. So we're working on reducing any sort of challenge or barriers that the child has to be able to use the sense in particular. And then waiting. right? Without auditory cues, because anytime you add auditory cues, you're increasing the amount of processing space the child has to use in order to do the thing you want. So you can give an auditory cue, but then wait longer than you think. And then wait a little bit more, and then wait again. And then you can try your auditory cue again, and then you get to wait again, because sometimes it takes a little while. And then, like I said before, having a visual anchor, I have had parents where, like, you know, fun stuff like 2024 glasses that have like, you know, pom-pom material on them, or cutting a hole in a colorful paper, shiny paper plate, or doing something that sort of is going to bring something that the child easily looks at and bringing that next to your face to treat it as an anchor. Or if you always wore the same hat while feeding, the child can acclimate to that hat. So anybody could wear that hat when it's time for feeding. And that would help the child cue into the fact that it's time to eat. Okay.
Should we do the video again, or are we feeling good?
Well, we could do it again, and then I could tell them about
Oh, that's a great idea.
the
Let's do it.
baby. And put
You want some more pouchy? No. You want water? Your hands up.
It always pauses there.
You want me to keep going?
No, it's totally fine.
Okay.
So things to know about this baby is she was diagnosed at age 6 with a near vision issue. She has amblyopia in her right eye, and so she sees far away better than up close. And she's pretty visually impaired. She's like a +4.5 on her good eye and a +5.5 or 6 in her weaker eye. But obviously you couldn't tell when she's that little. So she was working really hard to kind of get her eyes to work together. And actually her amblyopia pops up in her distance viewing. Who knew? But I don't know if you could tell, she wasn't really looking at me most of that video. She looked at her water bottle and then glanced up at her dad, who was holding the camera, and then glanced back down at the water. And then I gave her the pouch and she's like, forget you. And then I got the water right. But she doesn't do a lot of like eye contact with me. And I think that's partially because she was working hard to see stuff. And it was easier to see her dad, who was further away. She also met her motor milestones late, but not the fine motor, just gross motor. So she didn't start crawling till 10.5 months and didn't start walking till like 15.5 months. So, and then was very, very clumsy until she got glasses at 6.5. So you can miss it. It's totally normal to miss things because kids are tricky. And you know, she told her eye doctor recently, she's like, I can do everything without my glasses. It just hurts my eyes. And you know, by the end of the day, she was running into door frames and furniture and stuff because her eyes were so fatigued from just working so hard to work together and to do their teaming. So you can miss it. She looks totally typical here until you really start to pick it apart and know her background. But yes, there you go, babies.
Yeah. Here's our references slide, and then we gave Jessica's information. So if anyone needs Jessica's information, here you go. And then we gave some a little bit blurry screenshots from Washington State, who covers what area, which I found was interesting. And then here's our contacts with Elisabeth and mine on the screen. And that's it.
Ta-da.
Thanks for listening.
You guys did such a nice job, and I was writing down a couple of things, and I just really love to sit in on these kinds of things and hear how my colleagues talk about cortical visual impairment, or talk about how they use babies count. So that was really nice to hear. I love the example of the Dutton's, the camera and the filter, and that's really nice. And I don't think I've used that before.
I thought it was a really straightforward way to explain it in a way that other people might understand, particularly if they're not educational vision professionals. And then also, when we started making this, we got way too technical, like way too technical. And we were like almost done. And then we had this epiphany, like, oh no, we're going too deep. This dive is too deep. We are scuba diving when we should be snorkeling. So then we kind of backtracked and took a little more of a direct route to what we wanted to say.
I love that.
I liked it. Thanks a lot. I think one of the things I try to do is a lot of those suggestions. I mention that they're actually good for all kids. So if you're asking a baby to do something that's hard, simplifying the environment, making the activity really obvious, make the visual target easier to see, reduce distraction for the other senses. So, because I just find other providers are like, vision, they just get really, really overwhelmed. And so, I liked your suggestions, and yeah, they're good.
Yeah, and when I did the presentation, we were trying to preface it with, you probably already do these things because you're good practitioners, assuming that you're doing what you're doing because you understand infant and child development. But these will seem familiar to you. We're just talking about them from a vision lens rather than a feeding lens.
Yeah, and I kept thinking throughout the presentation too, and that might be true. People might, I mean, the feeding folks might be doing it, but I think there's a lot of value into having just even a brief conversation about the why part with the family. I mean, I keep going to PFR, so I'm thinking like this helps, those social emotional needs, whether it's, helping them to feel confident or giving them just the right amount of support with the hand under hand, yada, yada, yada. But I mean, anything, this is why we do that, to make, like Colleen said, to simplify the task. And this is not for, just your child who has low vision, but, for all babies. And I think that's really nice too, Colleen, because it really normalizes it. And I think that's a good thing for parents to hear.
I do have a little question. Was Dad, because I know she was looking at Dad a lot, was he able to practice what you kind of modeled in that interaction?
Yes, he was very good at feeding her. Yes, he was great at feeding her. She is a really good nonverbal communicator, and the reason why we had the water away from her at that time is because she was a thrower and was just learning how to tip the cup back. So we were in control of anything, because we also had a dog who loves snacks. So if once things go down, then we don't have access to them anymore because they've been eaten. So we tried to limit, just by virtue of the dog, we tried to limit what was on her tray to really help her focus on them. And I actually think I might have made that video for Tracy Gaver. So I think it was just to demonstrate typical vision in a child that age, and then turn out 5 years later that she actually could not see. But she was using her other sensory channels very well.
Dogs are the ultimate vacuum.
She used to like have her hand covered in food and she would just hold it down on the side of her high chair and let him clean her hand for her. And then she'd go back and like just work on her immune system a little bit. And it was great.
That was a learned experience.
Yeah, it was very predictable. He was always right there to
And
help
she
clean her hand.
and she has perfect attendance at school. Never sick.
Although she did just miss the last 2 days of school because she's sick.
Oh no.
But I think she got that from her brother. So, but yeah, her dad was really good at waiting. And he was actually, he did a great job feeding both babies. She had a little more, we had a little more control with things. And then the second kid was baby led weaning and it was hilarious and messy and nasty. But she had so much hair. I don't know if you saw that hair. She was born with that hair and like self-feeding. You got to be mindful of that because it's everywhere. So
Bath time after.
yeah. Once a day, feed yourself once a day.
Hey, I just had one more thought, and if you don't mind, I'm gonna share my screen for just a second. And I couldn't help but think about how this new in the CPI protocol from Perkins. Are you guys looking at the synthesizing direct?
Yeah.
But this has an opportunity for you to add images, and I was just thinking, okay, that that visual attention piece when you were talking about visual attention, adding a photo in there, and I can't even remember what exactly you had said for that, but then even coming down to access to people, and if one of the strategies is to use a color anchor or the glasses or whatever that is, just using this form, maybe considering feeding when using this form.
Mm-hmm.
And I know I told you, Elisabeth, that I just had just a total epiphany when I watched your presentation in April that, I just was really thinking about, potentially you could have 3 of these routines a day and how powerful that is, 3 or more.
Yeah, right. Because babies eat, I mean, once they're actually doing food, it's like 5 times a day at least, right? Depending on the child. So
tapping in to these routines and these opportunities, just really meaningful. Thank you guys so much for helping to educate non-TBIs. It's really cool to see, professionals get together and learn about what we do.
it does.
Does anybody else have any more questions or comments? Well, we really appreciate it. Yeah, thank you so much. And I hope you guys enjoy your summers. Please reach out if you need anything. And I'll probably reach out sometime end of August and see what we can do for that next, getting that next meeting scheduled. And I may do that soon, just so that we can all get that on our calendars. But then I'll leave you alone until later on in August. All right, everyone. Have a great afternoon and evening. Take care.
Thank you.
Bye-bye.